Professor of Neurology and Director of the Sleep Disorder Center at Northwestern University. I'd like to first talk to you today about insomnia in the older adult, a population that are at particular risk for insomnia. This will give you general background information before we get started into pharmacological treatments. Prevalence of insomnia increases with age. In young adults, the prevalence is about 10% to 15%. However, in those aged 65 or older, nearly a quarter of the population has a diagnosis of insomnia. It is commonly thought as one gets older, poor sleep is just a normal condition, and that it's common in older people to have insomnia. Indeed, it is common. However, a large study by Foley and colleagues show that insomnia is often comorbid with medical and psychiatric conditions, and that the prevalence or incidence of insomnia in the very healthiest of the oldest people are actually dramatically quite low. In fact, actually less than that of a younger person, about 10% or less. This indicates that it is the comorbidities with other medical and psychiatric conditions that contribute to the high prevalence of insomnia in older adults. Sleep complaints are common and chronic in older adults. This study looked at the frequency of the most common types of sleep complaints, including difficulty falling asleep, difficulty staying asleep, or just early morning awakening. What's really intriguing is that older adults not only have difficulty falling asleep, but they also have higher levels of difficulty maintaining sleep, as well as early morning awakening, and also daytime sleepiness. As you can see, about 20% of older adults have daytime sleepiness. When we looked at the same population 2 years later, they found that the symptoms of insomnia persisted. It is therefore important to treat older patients with insomnia early on because the problem just does not go away. As we spoke about earlier, much of insomnia in older adults is comorbid with psychiatric and medical conditions as well as neurological conditions. But what are some of these underlying causes? We know, for example, that alterations in circadian rhythms and sleep regulation related to aging itself can be contributory factors such as lighter stages of sleep or frequent awakenings during the night can certainly contribute to the high prevalence of insomnia. And these changes can lead to difficulty falling asleep, staying asleep. It's a myth that older people need less sleep. In fact, although they may be getting less sleep during the night, they're actually sleepier during the day. There are also medical and neurological and psychiatric conditions associated with age that can contribute to insomnia. For example, chronic pain, respiratory disorders, pulmonary disorders, depression, and also primary sleep disorders such as sleep apnea and restless leg syndrome. And lastly, psychological factors such as lifestyle changes, particularly late in life pressures such as loss of a spouse, death of friends, moving from home to, or for example, either nursing home facilities or recovering facilities can also be life stressors which can contribute to insomnia. When we look at older patients with Alzheimer's disease, sleep is even more disrupted than that of the general older adult population. Disturbed sleep in Alzheimer's patients is thought to be due to disruption of the circadian system. And there are some studies to show that indeed there are changes in the suprachiasmatic nucleus or the circadian clock of these individuals. Some of the causes include behavior disturbances, including the kind that make it difficult for caregivers to continue to care for these individuals in their own homes. And in fact, sleep problems are a very common cause for nursing home placement. We also see consequences of decreased melatonin levels in many of these older adults with Alzheimer's disease. Lack of sleep or sleep fragmentation can certainly contribute to further cognitive decline, and this is a cause of nursing home placement in many of these individuals. Older adults in the general population also have a particular change in the pattern of their sleep-wake cycle. The sleep-wake cycle actually tends to shift to an earlier time or advance in older adults, and this pattern is seen in over about 50% of older individuals. Some of these individuals actually meet the diagnostic criteria for what we call advanced sleep phase syndrome. This is a condition thought to be due to an alteration in the timing of the circadian clock itself, in individuals having difficulty with being sleepy too early in the evening and difficulty with early morning awakening. This is again a very common pattern with increasing age. As mentioned earlier, the healthiest of older people actually don't have much insomnia. It's really those older individuals with comorbid medical and psychiatric conditions that explains, at least to a large extent, the high prevalence of insomnia. Looking at the prevalence of insomnia in these comorbid medical conditions, whether it's mild insomnia or severe insomnia, those patients who, for example, have hip impairment, myocardial infarction, obstructive airway disease, or other types of cardiac disease like angina, congestive heart failure, prostate problems, metabolic disorders like diabetes, all have a higher prevalence of insomnia when compared to that of the general population. Therefore, it's very important in older individuals with comorbid medical conditions to be thinking about their sleep quality and asking about insomnia, because it's very likely that they will have insomnia complaints. In addition to comorbidities with medical conditions, insomnia in older adult individuals may be associated with primary sleep disorders, such as sleep disordered breathing, periodic leg movements of sleep, and restless leg syndrome. These conditions all increase with age, so that by the age of 60 years or greater, nearly 50% of these individuals may actually have sleep disordered breathing, and similarly, a little under 50% may have restless leg syndrome or periodic leg movements of sleep. Both of these conditions can be treated because they can contribute to insomnia. They need to be treated in their own right, as well as to improve the symptoms of insomnia in older adults. Why it's important to treat insomnia in older adults? Poor sleep has been shown in many studies to lead to difficulty sustaining attention, performance issues, cognitive impairments in older adults who already are generally predisposed to developing cognitive impairments. And very importantly, patients with insomnia actually seek healthcare resources more often than those who do not have insomnia. Especially in older adult populations, the consequences can include increased risk of falls, as we will discuss, also shorter survival rates. Very importantly, from a personal and social standpoint, an ability to enjoy social relationships. There's now more data showing how poor sleep can also lead to increased perception of pain, and perhaps improving sleep can also improve pain management in older individuals as well as in the general adult population. A study by Krikl showed that chronic insomnia independently predicts cognitive decline in elderly men. When we're talking about men, chronic insomnia clearly increases the odds ratio of cognitive decline. Again, this shows the importance of treating insomnia in older adults. In the same study in women, chronic insomnia was associated with increased risk of cognitive impairment, but only in those with high levels of depressive symptoms. This study demonstrates insomnia can increase the mortality risk in older adults. What's interesting is that if you look at individuals with sleep latencies greater than 30 minutes or sleep efficiencies of less than 80%, both of these are actually fairly good indicators of insomnia. You can see that those patients with insomnia complaints actually have an increased rate of decline in terms of survival as a function of sleep latency as well as sleep efficiency. To summarize, insomnia is often comorbid with medical and psychiatric conditions, and insomnia in older adults has very important consequences not only at a personal level, but also at a societal level.
In the next segment, Dr. Z discusses treatment options for insomnia. She focuses on issues surrounding treatment of older adults, where side effects and polypharmacy can be particular concerns.
When we look at pharmacotherapy, the most commonly used are the sedative hypnotic benzodiazepine receptor agonists, which are approved by the FDA for the treatment of insomnia. These include both benzodiazepines as a class as well as the newer non-benzodiazepine chemical compounds. They are, however, all benzodiazepine receptor agonists. Their mechanism of action is that they act by modulating the GABA-A receptor complex, so they have the same mechanism of action. There are, of course, potential advantages to the sedative hypnotic benzodiazepine receptor agonists. They are rapidly absorbed. They have been shown to be effective in the treatment of insomnia. All of them shorten sleep latency. Some also decrease the frequency and duration of nighttime awakenings, and some also increase total sleep time. Benzodiazepine receptor agonists work via modulation of the GABA-A receptor complex, and the GABA-A receptor has actually several subtypes. When compared to the benzodiazepines, the non-benzodiazepines are more selective for the alpha-1 subunits, which is where the sedative effects primarily reside. The point here is that the alpha-1 subunit not only is responsible for the sedative effect, but also for the amnestic effects that are seen with the benzodiazepine receptor agonists. So it is really difficult to separate the sedative effects from those of the amnestic effects. It is not surprising that older adults use a good deal of hypnotics. This is because the prevalence of insomnia, as you heard, is very high in older adults. This is true for both men and women, but particularly with women across all age groups. Women have more insomnia compared to men and higher use of hypnotic medications. The prevalence of hypnotic use in older adults is of concern with regards to safety, particularly when we're dealing with the benzodiazepines and some of the benzodiazepine receptor agonists. This meta-analysis looked at the risk and benefit of sedative hypnotic use in older adults. Most of these were benzodiazepine receptor agonists. They looked at two primary concerns in clinical practice: cognitive and psychomotor adverse effects. Their conclusion was that in the older adult, the risk of cognitive adverse effects outweighed the benefits of using sedative hypnotics. Similarly, when looking at psychomotor adverse effects in older adults, the conclusion did not favor the use of sedative hypnotics based on the risk-benefit ratio. Psychomotor side effects such as dizziness, loss of balance were 2.25 times more common with a sedative hypnotic use. A very large study of 34,000 nursing home residents recently found that insomnia itself may be linked to falls in older adults, whether related to the use of hypnotic medications or not. The debate continues whether the increased risk of falls in older adults with insomnia is related just to the insomnia itself or to the sedative hypnotics. In my opinion, it's a combination of the two.
Next, Dr. Z reviews the regulation of sleep and wake and the role of the suprachiasmatic nucleus, or SCN, the circadian master clock.
The SCN, or suprachiasmatic nucleus, is the master circadian clock and is located in the hypothalamus. During the day, the activity of these neurons are actually quite high, and it is hypothesized that the activity of these neurons promotes wakefulness or arousal during the day, thus helping us maintain wakefulness during the day. Whereas at night, during the normal sleep period, the activity of the suprachiasmatic nucleus neurons is attenuated, and it is thought that this decrease in the firing rate of these neurons is what tips the balance in favor of sleep, thus promoting sleep. Activity of the SCN is modulated also by melatonin and melatonin receptors in the suprachiasmatic nucleus. There are two major receptors involved in sleep and wake regulation, the MT1 and MT2 receptors. Animal studies have shown that stimulation or agonism of the MT1 receptor by endogenous melatonin attenuates the firing rate of the suprachiasmatic nucleus neurons, and thus is hypothesized to promote sleep. Whereas the MT2 receptors are predominantly involved in timing and synchronization of circadian rhythms. I hope that the information provided on insomnia in the older adult population and the science of sleep and wake regulation has helped you better understand the challenges in this patient population.
Next, Dr. Z continues with a look at the product profile of Rosarum, also called Ramelteon, indicated for the treatment of insomnia characterized by difficulty with sleep onset.
Our understanding of the MT1, MT2 receptors in the regulation of sleep and wake helped lead to the development of Rosarum, which provides a novel mechanism of action for promoting sleep. Rosarum or Ramelteon is a potent and very selective MT1, MT2 receptor agonist. It has negligible affinity for a third type of melatonin receptor called the MT3. Now, we know very little about the function of the MT3 receptors at this time. It also has negligible affinity for GABA-A receptor complex, which is the main mechanism of action of most sedative hypnotic medications. MT1, MT2 receptors are commonly associated with the maintenance of sleep and wakefulness. Rosarum has a half-life of about 1 to 2.6 hours, kind of an intermediate half-life. It's also important to note that it does have an active metabolite with a half-life of approximately 2 to 5 hours. Rosarum is structurally different from melatonin. Rosarum has higher binding affinity than melatonin and is more potent than melatonin. Rosarum also has different metabolites than melatonin. It has an active metabolite that selectively binds to the MT1, MT2 receptors, whereas melatonin's metabolite is N-acetylserotonin. There's a large volume of data supporting the efficacy of Rosarum in the treatment of insomnia. And a number of studies establish efficacy in both objective and subjective measures. Here are some examples. When we look at older adults with chronic insomnia, you can see that when compared to placebo, Rosarum of 8 milligrams significantly decreased the time to fall asleep using objective parameters. A large study of older adults with chronic insomnia looked at patient-reported time to fall asleep. This was a 5-week study comparing, again, 8 milligrams of Rosarum with placebo. You can see that during the entire 5-week period, Rosarum was superior to placebo in helping older adults fall asleep. And it is very interesting to note that there appears to be, at least between weeks 1 and 3, a continued improvement of the time to fall asleep in the group that received Ramelteon or Rosarum of 8 milligrams.
Dr. Z continues with a look at the safety data for Rosarum.
I'd like to begin with what is considered the gold standard in assessments of CNS effects and abuse liability. The subjects in this study had histories of polydrug abuse, or what I would call professional drug abusers, who are certainly not naive to the class of hypnotic medications that we're going to be talking about. In this study, they compared placebo, Rosarum, and the active control for a sedative hypnotic, the gold standard being that of triazolam, a benzodiazepine. The studies looked at various kinds of effects on behavioral as well as cognitive performance. This slide shows behavior performance, and as you can see, as pretty much expected, as one increases the dose of triazolam, you can see the increased impairment in behavior performance using, in this case, circular lights, or looking at balance, in which these individuals were asked to stand on one foot. The effect of Rosarum is very notable. You can see that even up to 160 milligrams, which is 20 times the usual recommended dose, the response is very flat. No dose-related increase at all in impairment in behavior performance, and it was no different really compared to that of placebo. Very similar results were seen with cognitive performance, with triazolam, as expected, an increase in impairment in cognitive performance looking at the digit symbol substitution, and also short-term memory parameters, whereas again with Rosarum at very high doses, response was flat, no difference from that of placebo. Looking at abuse liability, Rosarum, again, when compared to placebo, was indistinguishable from placebo with these kinds of professional drug abusers. They didn't like it very much at all, and they gave it really no street value at all. They couldn't really distinguish it from placebo. Whereas with triazolam, you can see the potential for abuse liability, which is a contributing factor to the scheduling status of this medication. Additional safety data for Rosarum includes no clinically meaningful effects with respect to respiratory function. There's been studies in a subgroup of patients with mild to moderate COPD or sleep apnea. It's not been studied, however, in patients with more severe COPD or sleep apnea, and therefore is not recommended in this group. But in this more mild to moderate population, it's been found to be well tolerated. Additionally, there were no next-day residual effects, no significant rebound or withdrawal effects, no abuse liability or tolerance, as we already discussed, and no changes on the EKG. Rosarum in some of the clinical trials has been shown to decrease testosterone levels and also increase prolactin levels in women. However, the clinical significance of these, either the increase in prolactin or the decrease in testosterone levels, is unclear and unknown. There are no clearly related clinical adverse effects that one could directly relate back to these changes. However, as a result, I think it is prudent for healthcare professionals to be mindful of any unexplained symptoms that patients may report that could be associated with these changes in hormone levels. Rosarum should not be used in patients with hypersensitivity to Ramelteon. And as I mentioned earlier, because it is metabolized by the liver, it should not be used in patients with severe hepatic impairment. The most common adverse effects reported were somnolence, dizziness, and fatigue. In the older adult population with chronic insomnia, the most common side effects were dizziness, myalgia, headache, dysgeusia, or kind of abnormal taste, and somnolence. To summarize what we have just discussed so far with regards to Rosarum in the older adult with chronic insomnia, the overall incidence of treatment-related adverse effects was fairly similar among placebo and Rosarum treatment groups. The patients who were on Rosarum did not show any clinically significant changes in any of these laboratory tests, and very importantly, in their EKG. And at this time, there's no outcome data on Rosarum. Rosarum is metabolized by the liver and is metabolized predominantly by the CYP1A2 isoenzyme, to a much lesser extent by the CYP3A4, which is common with some of the other benzodiazepine receptor agonist hypnotics. Because both are metabolized by the CYP1A2 isoenzyme, Rosarum should not be used in conjunction with fluvoxamine. To summarize, Rosarum provides a novel mechanism of action. It promotes sleep through the effects on the suprachiasmatic nucleus, or the SCN. It is indicated for the treatment of insomnia that's characterized by difficulty with sleep onset. Rosarum has been studied in older adults and therefore can be prescribed for older adults. There's no time limitation for the use of this medication, so therefore it can be used in those individuals that require long-term use. It does not promote sleep by CNS depression because it does not act on the GABA-A receptor mechanism. And as we've already talked about, no evidence of next-day psychomotor, memory, or cognitive side effects, which also contributes to a favorable safety profile. It is the only non-scheduled prescription hypnotic approved by the FDA for the treatment of insomnia. Patients should be advised to avoid drinking alcohol with Rosarum. It is also important for those patients who have not responded to the initial treatment for insomnia for us to reevaluate the possibility of comorbid medical and psychiatric conditions. This is particularly important in older adults who are very likely to have either depression and or other comorbid medical conditions. Rosarum is not indicated for children or adolescents, and therefore either the efficacy or safety in these younger populations is actually unknown. There is some additional safety information that I will want to share with you.
Important safety information. Rosarum is indicated for the treatment of insomnia characterized by difficulty with sleep onset. Rosarum can be prescribed for long-term use. Rosarum should not be used in patients with hypersensitivity to any components of the formulation, severe hepatic impairment, or in combination with fluvoxamine. Failure of insomnia to remit after a reasonable period of time should be medically evaluated, as this may be the result of an unrecognized underlying medical disorder. Hypnotics should be administered with caution to patients exhibiting signs and symptoms of depression. Rosarum has not been studied in patients with severe sleep apnea, severe COPD, or in children or adolescents. The effects in these populations are unknown. Avoid taking Rosarum with alcohol. Rosarum has been associated with decreased testosterone levels and increased prolactin levels. Health professionals should be mindful of any unexplained symptoms possibly associated with such changes in these hormone levels. Rosarum should not be taken with or immediately after a high-fat meal. Rosarum should be taken within 30 minutes before going to bed and activities confined to preparing for bed. The most common adverse events seen with Rosarum that had at least a 2% incidence difference from placebo were somnolence, dizziness, and fatigue. Please see the accompanying full prescribing information provided to you in this publication.
So to wrap things up, I've discussed with you today an overview of insomnia in older adults and some important developments in the management of insomnia, particularly for older adult populations. Thank you very much.
Thank you for joining us in this presentation by Dr. Phyllis Z of the Sleep Consultant Network.